Thank you so much. So I'm going to start. I hope we will end up having a good interactive conversation this afternoon. My name is Judy Wessels. I'm an occupational therapist by profession from South Africa originally, and I have been with Hope AMC for the past 9 months. I'm also fulfilling the role of clinical coordinator here. And this afternoon, we are specifically going to talk a little bit more about our intensive program that we offer for children and families who are traveling from abroad to visit our center. So when we talk about intensive therapy, it's really about the dosage of the interventions that we provide. And of course, it's being called an intensive intervention. We would like to have that high dosage of intervention. And that usually means 3 to 5 hours of therapy per week. I mean per day, actually. And then also the preference and the research is saying over a period of 15 days. So in essence, for us then, a good period of time to have an intensive therapy intervention would be over a period of 3 weeks, where the child is busy with therapy 3 to 5 hours per day for that duration of time. When we talk about dosage, it's also not only about the frequency. So frequency is definitely essential to have a high frequency. Like, for example, every day. However, intensity is also quite important. And then, of course, the time duration. Some children can tolerate a 30-minute session. Other children can tolerate a 45-minute session, and some others can even tolerate 60 minutes per day per therapy. So what we focus on when we do intensive therapy, we focus on repetitive learning patterns. Those learning processes are usually very task specific. So of course, when we start an intensive program, we do ask for previous reports. It gives us a good idea where the child is functioning at that stage. And then we also do our own assessment. The reason for that is so that we can work task specific when we are busy with repetitive learning processes. An intensive therapy intervention usually also involves what they call combined therapy approaches. In other words, the whole purpose of that would be to expose the child to different therapy theories, different hands-on clinical therapeutic intervention protocols, because when you work with young developing children, it is very hard to predict which kind of therapy will be appropriate for the child at that stage. So making use of combined therapy approaches during intensive interventions has shown through the literature to be the way of being the most effective. And then another fact chapter is definitely also to have actively participating parents. And usually that is the case. Children who comes from families where the family is committed to putting the time aside, investing the finances, those parents are usually very active in the process of therapy of their children. The reason for that is also, and I assume many of you who are participating this afternoon have a special interest in pediatric intensive therapy. But as we know, therapy is very much, yes, it's focused on the therapeutic intervention, but we also want to see the carryover, or what we refer to as the generalization of the skill within the child's context, and the family is very much part of that context. So another reason why we look at different therapy approaches is because we are looking at dysfunction at different levels. We are looking at sensory dysfunction, we are looking at motor dysfunction, perceptual dysfunction, cognitive dysfunction, as well as communication dysfunctions. So the eclectic approach towards intensive therapy blocks, therefore, is very much based on, includes theories around sensory integration, theories about motor control, task-orientated theories, and evidence-based theories, of course. Ultimately, what we're aiming at is then to improve the functional performance of the child. So, and for that reason, we also, of course, when working with children, we do look at the International Classification of Function and Disability, from the World Health Organization, where our therapy is not focused on one thing only. However, we do look at the body structures and function. So we do look at things like the range of motion in the joints, the strength in the muscles, the muscle tone, and whatever else, the sensory processing, the cognitive function, all those bodily structures and functions we are looking at. And then the next level of looking at how we approach a child with special needs would be to look at the activity participation. So on that level, we would look at things, can the child feed him or herself? What is the mobility of the child? What is the toilet habits of the child? And of course, then also the communication and language in terms of how to communicate with others. And then we also have to look at what we call the level of participation, which would include, say, for example, the child is now able to communicate with non-familiar partners. Is that child then able to apply this level of communication in an educational setting? For example, going to school or going to a play group. So when we plan an intensive therapy and when we focus on these repetitive learning processes, we look at all these levels. We look at the body structures, body function, activity? Can I use my muscles to grasp a spoon to feed myself? And can I do my feeding when I am in a social gathering with the family, or can I apply this feeding when I am attending my play group? Maybe before we go further, if I can go back to the timing when it comes to intensive therapy interventions. Oh, we actually did look at that. Sorry, I'm backtracking myself now. We did say that a period of 3 weeks is actually estimated to be a good period for an intensive intervention. The reason why I was backtracking that way is, you know, and this is a very delicate question that comes up from parents a lot of the time, is how will I know that the intensive intervention was successful? And it's a very sensitive matter for therapists, because there are a few things we know for sure. We know for sure the brain has got a lot of plasticity available to its growth and development when the child is still very young. We do know that. We also do know that therapy can improve or facilitate that neural plasticity in achieving better skills and function for children. What we, however, do not know for sure is what will the results or the outcome be at the end of the 3 weeks. So, for example, we work on an average of a 3-week intervention. What will the results be at the end of those 3 weeks? And you will hear that therapists are very evasive when they talk about this, because the honest truth is we cannot determine the exact outcome, because it's so individual to every child's own neurological constitution. So what the research has, however, showed is that often the positive evidence of an intensive therapy intervention is often not visible right after the treatment. So at the end of the 3 weeks, the difference is often not that evident. However, the literature is also indicating that if you have done intensive therapy over a period of 3 weeks, the possibility of that intervention being sustained after a period of 8 weeks is very good, and that you can expect functional changes to happen up to even a period of 8 weeks. If you look at a neurodevelopmental level to this, it actually does make a lot of sense, because just from normal development, we do know that sometimes neurotypical children, they might start to walk, and then suddenly they stop walking, or they walk less and they start to talk. And that is how the brain is integrating all these new skills, making sense of it, and then step by step progress to higher developmental levels. So even with an intensive therapy block, that makes sense, that if we do this intensive therapy with combined therapy approaches, it may take some time for the brain to actually produce a different functional outcome. So it's just important for parents, because of course, if you decide to invest in an intensive therapy block, there are inevitably there would be expectations of positive results. So, and of course, as a therapy team or a rehab team, we definitely also work towards positive results. I think the reason why it's important to understand that the improvements might not be visible immediately after the 3-week intervention is that the brain needs time to, we also call it habituate. So the brain needs time to integrate and to get used to these new skills, these new neurological connections that were established during an intensive therapy block. I want to also come back a little bit to neuroplasticity again. Like I said, it's one of the big advantages when you work with children with special needs is that we do work with a young brain. You know, and previously it was believed that this will make working with children easier. However, we should also remember that when you do work with a young brain, there are two things that's happening simultaneously all the time. There's growth and development taking place. And then when you are working with a child with special needs, there's alternative ways you have to approach working with this child in order to assist the child to fill the gap between the development that is taking place and the barriers there is to development for the specific child. So in essence, working with children is far more complex than working with adults, because when you work with an adult, you work with a fully developed brain in the first place, and you also work with a very extensive memory bank, if I can call it there. There's motor memory in the brain. There's memory around sensation and sensory processing. There's language memory. All of those memory banks are available that the brain that is now challenged can fall back on, rely on too. While with children, these two things they are a very dynamic process, and the child hasn't got that extensive memory. So you have to almost give the child more compared to an adult to make sure that you can really tap into the neuroplasticity that is available. Another thing that's quite important when it comes to neuroplasticity works quicker or more effective, if I can put it that way, when it has meaning to the child and when it has a function for the child. That's why it's so absolutely important for us to have adults in the child's world to assist this intensive therapy block, because you are the ones that can inform the team working with the child. What are the things that has meaning in this child's life? Bring a favorite toy, bring a favorite blanket, anything that is of significant meaning to this child. And we need to understand and we need to know what is the function of the child on a daily basis? What is the child's routine look like? What do you usually play at home? Because those functional tasks, if we can bring that into an intensive treatment block, the chances of neuroplasticity really working well is so much better. And also the chances of carryover, in other words, the sustainability of the intensive intervention on a longer term has shown to be better if the meaning and the function is included. So it really is therefore very important for parent and family member. I refer to parents. We've had other families before where the grandmother traveled to birth or even an aunt traveled to birth. So it's really very valuable to have the family members involved. So I think before we open the discussion, I can maybe give a quick summary of how we usually work. Should a family be interested to do an intensive therapy intervention with us, we usually have an online meeting with the parents. The reason for that is to really understand the child better. You will also know that our receptionist, our front office team will ask a lot of information. The more the information we have beforehand, the better we can understand the need of your child. So the information beforehand can therefore include medical reports, which is really preferred because it's mostly because of precautions. We do know that an intensive therapy block is going to be intensive. It's a little bit like boot camp when you want to get fit, or it's a little bit like a nutritional diet when you want to lose weight. But for us to be safe is quite important. Therefore, we need to look at the medical precautions before we even start. Then other therapy reports, like I mentioned earlier, is quite important. So if we've got a bit of that information, we also do ask a bit of video recordings so that there's a picture of your child available when we start with the online interview with the parents before we even plan the program. So yes, then we have, once you've decided you're interested, we have a bit more information about your child. We have an online conversation where we can establish if there are any more questions, where we can potentially discuss a preliminary plan. So that's quite important. And then after that, we will put a plan together for you. It's a very individualized plan. And it's very different for every child. Again, when working with children, it's very different than working with adult patients. You will come to know later on maybe that adult therapists are usually diagnostically specialized. In other words, they're a sports therapist, or they work specifically with the spine injuries or with neurological injuries. However, with pediatrics, with children, we are specialized in all the diagnoses and also in all the ages. Therefore, it's really very different to you. It's very unlikely that you have two children who will have exactly the same program. Programs are therefore individualized, which is why we ask all the details and we have the meeting with the parents. So then our team will look at your child's case. We will have it quick discussion between all the therapists in terms of what every therapy speciality will recommend for your specific child. And this is more where the frequency and the intensity and the duration of the session is involved. So, for example, when it comes to physiotherapy, we have the CME approach, which is an approach which is very much focused on motor control and the evolutionary developmental process of the brain. And we also have the neurodevelopmental or NDT approach to physiotherapy, which can be much more functionally orientated. So once we have all the information, the therapists need to have a discussion on what would be the best recommendation for this child. Also, when it comes to hydrotherapy, we need to decide what should be the intensity and the frequency of that, or sensory integration therapy, or functional occupational therapy, or more school-orientated occupational therapy, and speech and language and feeding therapy as well. We need to have a discussion there in terms of, is the emphasis going to be more on the feeding therapy? Is the swallowing safe? Is that where we need to focus on? Or should we focus more on functional communication, which might be, pre-functional, like eye contact or vocalization or making choices with adapted, and now I can't remember the correct language for AAC, alternative and augmentative communication tools. So we need to discuss, or are we actually at a level where we need to focus on the speech and the language of the child? So for each child, after we've had the discussion with the parents, we go back to the drawing board and we set up this individualized plan. And like I said right at the beginning, the combined therapy approaches has shown in research to be the most effective if you look at the short duration of therapy of 3 weeks minimum. So we often would send the parent a program, and then the parent might decide for various reasons that they will not go for the combined therapy intervention approach. I think we must just understand that the risk is then that the outcome might be less effective than when we use the combined therapy approaches. So once we have done the planning, we will send the program to the parents. They can have a look. We also often find that that parents will take the program to their current team if they are lucky enough to have a continuous therapy team at home. They even might discuss it with that team or with their doctors at home, their specialist doctors. And once we have received feedback from the family in terms of acceptance of the program, we then go further. The front office team, together with the clinic management, will then continue to operationally put the program and the plan in place. So that's more or less what the approach is towards an intensive therapy intervention. I would like to open the floor now. Amal, I'm not sure if you would like to add something at this stage, or if we would open the floor to anybody who would like maybe to ask questions. Just hold on a moment, please. Yes, Amal, please. I am not sure if I'm supposed. Karen, can you assist me? Because as far as I understand, everybody can unmute themselves. Oh, okay. You can unmute. Thank you for confirming that. That's perfect. Yeah, maybe to raise your hand and then to unmute. But Amal, I know you raised your hand, but I'm not sure if you are able to unmute yourself. Yes. Pukiri, would you like to speak? You're welcome to please have an input.
Hi, ma'am.
Yes. Good
Good
afternoon.
evening.
Yes. How are you?
I'm very good, thank you. And I would like to thank you for today's intervention. My name is Vidya. I'm from Mauritius. I'm a third year student from Polytechnic Mauritius.
Oh,
So
wonderful.
I am also a businesswoman and entrepreneur and a mother of a son, but unfortunately I couldn't join you earlier. I'm so sorry about that, but your summary just helped me out. Um, since I'm already here and you're already explaining about the intensive therapy, I would like to know if that can help autism children.
Yes, for sure. For sure. I have not mentioned this. It's a good question. Thank you very much. We also have ABA therapy, behavioral therapy at the clinic. So when it comes to the children on the autism spectrum, the shift then is more towards occupational therapy, speech therapy, and applied behavioral therapy. So we definitely do have that approach available. The ingredients of the recipe, if I can call it that, is then definitely just different. Speech therapy also at the moment, we have social groups. Of course, with that, it's a little bit more sensitive because by the time a child is able to join a group, they should be at a certain level to really get the best out of the group intervention. But we definitely do have the opportunity for children with autism. I think it's important to also remember when it comes to the combined therapy approaches, to also understand that, of course, these approaches might sound as if they contradict one another. It can really sound that way. However, that's why working in a multidisciplinary team, which is very much our setup, that's why that is so essential. Because when it comes to children with autism, for example, the occupational therapist might focus much more on the sensory system and also on what we call a bottom-up approach. So the body teaching the brain what it needs, where applied behavioral therapy and speech therapy might much more be a top-down approach, where the reasoning and the learning is also speaking to the body. So that's really why it is so essential to have a team discussion when you plan your intervention, so that you can balance the things out. In the end, all of us want to improve the progress and the development of the child, and therefore a team discussion is important. So I hope that that answered your question.
Yes, ma'am. Thank you very much for that. But I have a series of questions, and I think the time is really limited in here because my son was diagnosed autism since the age of 3, and now he is 8. And there are a lot of complications happening in both on both levels, both mental and physical. So maybe I'll catch you up later because other people might be asking questions too. It's just a
Okay.
last question. I'm from Mauritius. Where are you based? And is it do you have any such programs in here? Thank you.
So if you say here, do you mean Mauritius? Because unfortunately not. I think if you ask the team, we will all want to go work in Mauritius. But we
Yeah, definitely.
we are based in Dubai at the moment. But
Okay.
which
Yeah,
is
no, that's no problem. But can you do I don't know if the interventions can be done online or how is it done then? Is it remotely done?
okay. You know what? That also depends a lot on your child. It's not impossible, but of course it's slightly more challenging. But yes, I think unless there are other families who have similar questions, we can discuss that. You know, it depends. It definitely depends on case by case. We would still need quite a bit of information from you. We would still need to maybe have the initial discussion online so that we can see how effective it can be.
Yes, ma'am. Thank you very much.
Okay. I see here is another question from Vandana. Thank you for the question. I see your 2.9-year-old child is crying in physical therapy. Because of seizure activity. So it's also a very good question. So we have to be quite careful. And that's where it's very important to have the discussion with the parents beforehand. It's important to get a better understanding of your child's medical condition, because of course we don't want that. We don't want the child to be in too much stress, so that we don't disorganize. Disorganize is a nice way of looking at it. And you know, as one of the CME instructors is explaining it, it's almost like you work with your child in a frame, in a photo frame, and you want to stick into that frame, which is why we need the input from the parents or the medical team on your side. If you move out of the frame of your child, you're going to disorganize that child's system. And it is hard to know when you plan an intensive that this program will work out exactly like it was planned. We've recently had a family where we did all the preparation work very thoroughly. And in the end, we had to reduce the intensity slightly. And of course, the younger the children are, the more dependent are they on their basic routine of feeding, of sleeping. And it's also important to understand that, because if the child is used to an afternoon nap, to control their stress, it's important for us to maybe rather schedule the appointments in the morning. Simple things like that can make a rather big difference. Yes, so when we plan, that's exactly one of the reasons why we have to be quite thorough in the preparation work before you actually arrive. And once you've arrived, we need to have that little bit of flexibility. And I think a nice way of thinking about this is to consider the parent as the expert. You know your child better than anybody else. You know what triggers stress and what doesn't. The therapist or the therapy team is like the facilitators. We want to facilitate development and progress, definitely. But the child is the teacher. If we can have that metaphor in mind, the child is the one that is telling us you are sticking to my frame, or you are moving too much out of your frame, out of my frame. And their brains are the ones, and their cues of communication are the things that we have to be extremely attentive to, so that we stick within their levels of stress. And of course, by implication therapy, saying we want to stretch their abilities a little bit. But then I want to remind you of those spiral, it's like a spring toy that you buy in any cheap toy shop. Those little spiral springs that if you tip it, it walks over to this side. And if you tip it back, the whole spring is going to this side. It's like looking at that that spring or coil and stretching it. Therapy is supposed to stretch it, but you don't want to stretch it too far. And the way we know whether it's going too far or not is by looking at the child, see what the child can tolerate, and constantly adjust the therapy to that, so that we don't pull that spiral out too far and we lose control. So I hope that answers your question, Vandana. I see, Saki, you also have your hand up. Not sure if you would like to. It's a pleasure, Vandana.
Hello.
Hello.
Yes, I'm Sakina from India. I'm a pediatric physiotherapist. Actually, I have a patient, 9-month-old kid, who is diagnosed with achondroplasia. And the
Okay.
parents had come, achondroplasia. And the parents had come to me when they had gone to doctors. They had asked them not to go for any kind of physiotherapy till 1 year. So, is it advisable to start from 9 months or should we wait till 1 year?
Can you repeat the last little bit? Sorry, I
Yes,
lost you. Uh,
yes, no
the
problem.
medical team recommended to start only after 1 year.
Yes, so the doctors to whom they were consulting, pediatrician, have asked her to, take physiotherapy after 1 year of age. So I just wanted to ask you that is it okay if we start by the 9 month of age rather than going 1 year? Because I believe the faster we start with the neuro rehabilitation, the more chances for the kid to have developmental milestones at the correct, at least nearby the corrected age.
Sakina, I think for when we work with an intensive patient, I would go back to the medical team and understand the reasoning behind that, because if there is the potential of further damage to muscles or joints or connective tissues, I think it's just very important to understand the medical precautions of their reasoning. And then, of course, when we look at children, it is so much more important to work earlier rather than later. Um, when I was reading up a little bit, I came across, and it's on so many levels, which is why pediatrics is quite complex. But, for children, for example, with language or higher functioning challenges, the later you start, if you bring the child at the age of 8 years or 9 years, you've lost so much time that you make it much more complex. So, of course, in principle, we would like to have the children as early as possible, but always within the safety. And I want to refer back to the coil, the spring, or the frame. Even from a medical side, we need to make sure we're not harming opposed to improving. And with babies, the two things that are truly much, much more important is the whole thing about sleeping and feeding. If we can keep within their feeding and sleeping routine, we are going to do them much more of a favor than trying to fit their needs into our schedules. And it is really challenging also on an operational level, because therapists have many clients, and the schedules are often not as flexible. But as much as possible, if we can accommodate the basic needs of a baby. And then, of course, you also get babies that are far more sensitive in their neurological wiring, so they disorganize quicker. You can have a 9-month-old baby who can tolerate the same as a 2-year-old, but you can have a 9-month-old who can tolerate far less. So if we say, you know, we aim for 3 to 5 hours of therapy per day, that is truly an average, and it will definitely be less for real small babies.
Okay, thank you so much.
It's a pleasure. I see there's a question about if we have books that we can recommend for children on autism. I think I need to have more clarity. Is it books for parents to read? Or is it books for the children themselves to use? Oh, on autism, for children on autism. Well, you know, I will not be able to assist a lot in that. We can definitely combine a list for you, or we can see what resources we can maybe make available on our website in terms of recommended books. But the one book that from an occupational therapy point of view that's really nice for parents to have is a book they call the Out of Sync Child. It's a very practical book. It refers to the different sensory systems, and then it also includes lovely home-based activities that you can do with your child. Anything from messy play to, you know, making use of swings or balls or trampolines. So that's one name. I can maybe write it. I can't remember the author now, but it is a lovely book for parents to look at to understand their child's sensory system a bit more. Sakini, I see your hand is up again. Do you want to ask
No,
another?
no. It's completely that was the first question that I wanted to ask. It is
Okay.
answered. Yes.
Okay. Okay, I'm not sure if there are any other questions or comments. All very welcome. Okay. So if there's no other questions, I hope I didn't miss anything in the chat. I think I don't think.
Yeah, so Jury, thank you so much for all this information. But how are you going to take get connected? Will you set a meeting on a one-to-one, or how do you do it? Via Teams, Zoom, or you send an email? I want to know.
So we usually, Karen, who's our front office leader, she usually will there will be WhatsApp and email communication with you. You can contact us either via email or WhatsApp. And then Karen and her team will make contact with you. They will ask you the initial information, like how old's your child, what are the challenges, do you have any reports available or videos? And after you've sent us information, then Karen and her team, excuse me, they will set a Teams meeting with you. And that
Okay.
that discussion is then usually with me, where after that discussion, I then take your information and your reports and video clips and the information from the discussion. I then present that to the therapy team, and we all sit together to look at the plan for therapy. After the plan has been written down in a short format, we send that back to you. And then the front office team and myself and the therapy team can coordinate, because there's often questions. So, for example, we present the plan to you. Parents have questions, they might say, okay, we wonder about the intensity. Is it going to be too much or not? So it's sort of an ongoing discussion. I think the big thing we need to remember is that if you exclude one therapeutic intervention, and yes, definitely for children with autism, we include the behavior therapy, but if you exclude one of the therapy disciplines completely, you might have a different picture. But once the plan is agreed upon, then Karen and her team, together with Mr. Tagwat, who's the clinic manager, and the finance team, they will put together a quotation. That will be sent to you. And once you've accepted the quotation, and the front office team, of course, are much better at communicating with you with regards to the processes of payment and invoicing. But once we've agreed on the plan and the quotation, we can get into putting the plan into practice in terms of dates and times and accommodation. Parents usually ask a little bit of advice with around all of that as well.
Okay, great. Thank you very much, Judy.
Okay.
Maybe in the future I'll be joining you in Dubai as a nurse. I don't know yet. Haven't planned it.
Yes, but it's good to gather information and to to slowly make decisions, to start to think about it.
Yes, definitely. Thank you.
Okay. I see we have run out of time. I'm not sure if there are any other final questions. So I don't see any hands. I can talk forever, so I think we must end. I'm sure everybody has something to do or planned for the rest of the evening or morning. Thank you so much for joining, and please do not hesitate to ask any further questions via email should the need exist. I see someone is typing. I can't see who it is. Let's just see. Don't want to cut anybody off. It's a pleasure. It's been a pleasure. Thank you so much, everybody. Karen, I'm going to end the meeting, or are you going to do it from your side?
Bye, Judy.
Thank you. Bye-bye. Bye-bye, everybody.
I'm gonna do it on my side.
Okay. Thank you so much, everybody, for joining.
Thank you.
Thank you.
Thank you.
Bye.